Now, this article by Nevins was interesting because he laser etched the bottom of an abutment, as you see here, and what was interesting is that he showed that there was a biologic width, but instead of there being a longer junctional epithelium and a smaller connective tissue zone, there was more connective tissue and a smaller epithelial connective zone, attachment zone. And we're not sure if that clinically means anything, but it's rather interesting to show that he was able to get attachment sometimes onto the abutment. But these were not changed and they were not an occlusion. So don't be confused by this. Soft tissue does not need a rough surface to attach. Soft tissue can attach to any clean surface. It just has to be clean. It can be perfectly smooth. That's different than bone. Bone, as you know, always requires a certain texture. Otherwise, it doesn't attach. So will we ever get to this where we see, like on the left you have a tooth, on the right you have an abutment and a crown? That's our goal, interproximally and facially. But can we do it, and how predictable is that? That's really our goal. So between two implants, what we'd be looking for is eventually getting a scalloped abutment, and that will hold the soft tissue and then not lose the papilla. So the treatment plan today is what? 2 implants in the centrals. We put 2 implants on. And we get on the left, you see the black triangle. We see the black triangle. All we do today, and we get away with it with 2 centrals, is just make the square like we showed before. Long contact area, yeah. Because people accept that because it's right down the middle, there's no asymmetry to the eye. The real problem is a high smile line. Someday we'll be able to do this. Put 2 implants in, 2 abutments with scallop, leave them in, let them get supercrestal fibers, and get a normal papilla, an extra 1 or 2 millimeters high. And that's what we have to try to get predictably. And then we have a normal papilla instead of a short one with fat contact points, short contact points. This is the one that we certainly know that we don't want to do. A central lateral with a high smile line, and the other teeth look perfect on the other side. And you know what happens here, right?
You always lose it.
You always lose it. And so you see the papilla is gone. So what we do is do the ovate pontic, and Glauber and Salama will talk about that in a few minutes. The ovate pontic, or possibly saving a root and holding it underneath, which I think is intriguing too.
Great idea.
And the other way is the cuspid. You can't leave the lateral, take the occlusion off of the lateral, and keep going from there. 4 in a row, basically do the laterals, then the papilla comes back between the cuspids, and then you can build up a nice ridge and scallop 2 ovate pontics in the middle.
And we've done that.
And
you have a nice little technique of how to even manage the papilla between the 2 pontics.
Right, between 2 pontics, right. If you do 4 in a row, you have symmetry, but everything's short. All the papilla are short and the teeth are square. It doesn't look as ideal. So it's not the first choice. So, can we repair the problem? The last part. So,
this particular patient, like we were saying before, is that even on these teeth, she's barely maybe showing the midfacial on the right central incisor, but clearly the loss of the interdental papilla between the 2 implants is the key factor. That's a really big factor. So you can see here that this particular patient, as we started out, when Dennis showed her case initially, that she was losing the interdental papilla between the 2 implants, and what she winds up having is an unusual papilla ratio to contact area. The contact area is just too long and excessive.
When this patient came to us, she was near tears. She was in tears because this is the way, she's a pretty young woman, this is the way she looks. She can't smile. Now we could, probably just make some peak, Steve and Adam and our technician can do some magic, but it's still, look, she's in the smile line, and it's really a problem. And so,
and David and Maurice and Christian
That's
Coachman has published a lot of these articles, 3-part series in Ron Nevin's journal, beautiful work on how to manage prosthetically the loss of the tissue with a prosthetic solution.
So look at the problem here. Let's go to the next slide. And the problem is that she's lost this papilla, and the implants are too close together, and they shouldn't be together to begin with. This is exactly what we were just talking about. Can we solve this problem? Next, please. The implant's integrated, and so if you take a look at the height difference, what do we got here, Steve?
Well, when you really think about it, I mean, this is a tremendous amount of loss of tissue interdentally. And so many people, like we said, focus on the midfacial, but our goal is always the interdental because, you can manage the midfacial very predictably, and I've seen you do that so many times, but the interdental is really the key factor. And that becomes our endpoint. We really look at that. And what we've learned over the years is that as long as these implants are healthy, we've done this for single teeth as well, is that burying healthy implants will allow the tissue to close over, like patients who have missed the healing abutment falls off, they come back, you look in the mouth and go, where is it? So we know in health that this should cover over. So basically,
I said to Steve, I said, just put on fresh cover screws, let nature start to fill in the void. The first thing you do whenever you're missing soft tissue and bone is go for the soft tissue. Every surgeon knows that because then you can have the blood supply to be able to create the bone. So just putting the cover screws on, it's similar to what Langer talked about with decoronation of a tooth. Let the tissue grow over for a few weeks, let nature fill in. But the first thing that's so critical for every surgeon and restorative dentist to talk to each other is get rid of the original temporary and make it temporary with what? Ideal crown contour. And so
I actually spend a lot of time. What I learned from you, Dennis, is the following, is that you always like to allow nature to take its course and allow nature to help you in the final result. But the key factor is that the surgeon has to really be able to visualize in 3 dimensions what the restorative dentist is really looking for. And so what I usually do is I spend quite a bit of time on the provisionals, and I always add pink. Because then dentists could take a look at my provisional, remove it, look at it in 3 dimensions and say, oh, so Steve wants me to not just do facial correction, it's interdental and maybe even some palatal.
So this is really the surgeon's guide. Those don't get 2 temporaries that are big and filled with white. You must make the normal proportion of what the restorative dentist knows that he or she wants, and the rest pink is the surgeon's talk. If you would then surgically look at this case, you have to be honest with yourself. Surgically, all your surgeons out there, whoever's doing the rest of the surgery, you say, can I fill in the void? Is it also just buccal, lingual, or is it height also, which is, as we know, is much more difficult?
It's a great
and you got to be honest, right?
It's a great communication tool for the restorative dentist and surgeon, and also great communication tool to the patient, because the patient wants to visualize, well, what are you thinking, doctor? I mean, where are you thinking to bringing me back to a state of aesthetics again?
And this is an important point about the patient, because sometimes after the beautiful temporary is made, with pink ceramic, pink acrylic, we then say to the patient, now listen, this is what Steve in our lab can do. The question is this acceptable to you? Meaning a prosthetic solution to the problem you have. If not, you're going to have to go through multiple surgeries with me to be able to do this and have, a bit of an unknown entity sometimes, but we have to go through this, and that's what we do.
It's a great discussion. It's a great decision-making process that
so this is what we
helps the
decided.
patient.
So we decided to put the cover screws on. You see the void in the back. Don't put anything in the way. Let tissue grow in by itself. We're going to go through this quickly now. And let's look at what nature did for us. Fresh cover screws. You see that we got some coverage over the top. Now I have some extra tissue already to start doing something. And within 3 weeks, look at what happened. It won't cover completely because there's that little hole that will always stay there because of the cover screw hole. It's filled with bacteria. So it never completely covers, interestingly, unless you surgically cover it, which we're going to do. So we let this go. At first surgery, next please, I open it up. Now the first thing is you notice I did a papilla saving procedure. Notice I did not open a papilla. One of the main things that I like about this case, for me, even though it's a terrible case interdentally, the papilla is gone, is that there's still papilla on the adjacent teeth. So that's great, because this way I don't have to reform them, and that's my blood supply. So I'm going to leave them alone, and all the surgeries you'll see will be papilla-saving techniques. I open it up.
And this is an interesting case, because I made a fixed provisional for her, and the only tooth that it was anchored to was tooth number 8.
Right.
The reason why is that she had a very shallow over-jet and over-bite relationship. She wasn't a bruxer. She was careful with it, and it really allowed us to do this, because having a fixed restoration is one of the most critical pieces to allow the surgeon to do what they need to do.
Ridge. And that 6 retainer would be another choice.
Yes.
But this worked out pretty well.
Yes.
Or a bonded temporary.
Bonded temporary or
Maryland bridge or something.
Yes.
Okay, so now what I'm using now, I was just starting using this at this time a few years ago. It was the Puros dermis. This is an allograft. It's dermis. Another one could be alloderm or perioderm from Dentsply. It's really dermis. Now this is interesting. Let's watch what I did. It's basically skin from human allograft, dermis. It's deepithelialized. Next, please. And I actually placed it in like I would a connective tissue graft. It's dermis. Next, please. Now, because I wasn't sure how well this is going to hold up, I didn't want it to get it exposed, I put a big connective tissue graft, I de-epithelialized it, and then I placed the connective tissue graft over the top. This gave me extra bulk. Next, please. And here you see the first attempt closed. Today I would do more aggressive. Today I would put multiple layers in, which I would do. So here I did a fresh connective tissue graft plus a dermis graft. Next, please. Notice that the pink is, in 1 week, most of the pink is gone. I don't have my full height and it's a little swollen, but notice that I have already taken down a huge amount of the pink that was on the temporary.
We remove the pink and the pink becomes your guide, surgically.
Absolutely. Let's keep going now. Second surgery, 3 months later. I go back in, again papilla saving, get a little shrinkage, put it back in, do the same thing. Now today I would do 2 right away, 2 layers right away. But again, I was a little afraid to push the system. This was one of the first times I used this material. Next, please. And plumped it out again. Next, please. We keep going. Plump it out again. And there it is at 1 week. We're starting to get a little good shape. Next, please.
And at 3 months.
And then at 3 months. So it's pretty doing well. So remember the papilla height before was really, a problem. So now I'm starting to get, I'm a little deficient, but not bad. Next, please. The third surgery. Next, please. Go again. And I opened it again and added more. I couldn't plump it out. So I put another piece in.
I remember asking you this question. I said, Dennis, it says on the package, it's 0.8 to 1.8. And you said, well, it's like a box of Cracker Jacks. Sometimes you get 0.8 and sometimes you get 1.8.
It is, because when they do the derma graft, they get different kinds of skin levels in certain areas, at least for the puros does. Next, please. And so here we're putting it in. Next, please. One of the little techniques that you see is I suture it to the palate, and that stabilizes it in place. And then I'll put that one suture in, and then tuck it up under, release the flap, and get primary closure. Next, please. I like that. And so here you see the suture that's holding it in, and then I just put primary closure. Notice I've never opened the papilla on this case. Otherwise, you tend to lose the bone there, and you can lose the papilla. In all these surgeries, I've kept doing papilla-saving procedures.
But I also, I had asked you one other question one time. I said, because sometimes I see so many surgeons putting in so many sutures, and you say to me, well, sometimes it's really about blood supply. You don't want to suture. So
okay, we move along now. Now, here's the problem. I have to now uncover this in some way. Next, please. I have to uncover it. Here's what we started with. Here's after the second surgery. There's after the third surgery. And now I'm going to have to uncover one for Steve to then hook his bridge on, hook the crowns on. So now we're going to have to decide that we're going to open one tooth and try and cover the other. So you notice how conservative I was. I have to keep one submerged onto here, and while I open one, open the central. And we're going to make an ovate pontic eventually on the other. So I open it up very conservatively. Steve then does his thing.
Yeah, I just put a screw-retained provisional abutment, then I reline that to the existing provisional. And you can see here that I'm just trying to flatten out the contours, because the problem before is the following, is that this is quite a bit of tissue, but it's hard to get it to lay flat. So the key factor for me is that subgingivally I had to make sure that the contour was very flat. So I add acrylic in this area, and then I can go back and try to make sure that the contour subgingival is flat, and then understanding where my supragingival contours will be. So I shape it up accordingly, and then I can give it back, and then you can go ahead and try to adapt it.
It was too thick in one spot. I had to thin it so it would lie flat, and I could suture it a little bit better.
So the key factor is that, trying to lay it flat. You actually had to thin it out in this area so that you could actually suture it closed. So contour becomes a critical factor when doing that procedure. After we get a couple months of healing, then I just make provisional. You can see here a little bit more, and then you go back, and you're going to now do a subtractive procedure because you've augmented the site so much. In other cases where it's deficient, you have another technique, but in this one where you've augmented it amply, then you can do a subtractive procedure and just take one of these football diamonds from Brasseler.
The other reason I didn't open up a little slit or something is that, remember, there's a cover screw under here. It's not a regular ridge. So I just did a little indentation, and Steve relined it.
Yeah, then I could add some acrylic. Yeah, typical ovate pontic. I can just reline it, and then you just did a little gingivectomy just to correct the zenith. On number 8. On number 8. Just while you were there, you just correct the zenith based on studies we know. It's roughly about 1 millimeter distal from the midline. And then we go ahead, we have now the provision. Now, she's definitely in a lot better situation. Remember, number 8, number 9 is the implant, number 10 is the pontic.
Notice that even with that, the papilla did shrink back a bit from what we had. It's very tough
still a
to
little
do
bit
this.
deficient.
Right. So then you did your thing here.
Yeah, then we go ahead, we make the impression. You can see again what she started out with and what after the surgeries that you did for her, you were able to correct the mid-facial
Show that again.
perfectly.
This is not.
Yeah, you were able
to
to
just show the morph. This is before, and it morphs to the after.
Yeah.
So
you're really able to correct, mid-facially, super, and interdentally also great, trying to get that down as much as possible. I go ahead, I make the pickup impression, and then we can make the cast in the lab, and then the technician can then wax the abutments. In this situation, we have plenty of tissue, so using metal is not a problem. We usually gold plate afterwards. Some studies by Shigemi Nagai at Harvard shows that gold plating works well. And we can go ahead with the framework. And again, working off of solid cast, Louis Santiago, our lab technician, does a beautiful job with the metal work. Really having a nice support to the ceramics. Metal ceramics, if done properly, is a great solution. I know Jorg came and talked about some of the issues with long span and abutments that are not supportive with zirconia. It can be a problem. You can see here how much tissue you were able to really augment. So I had plenty of tissue here. So having metal as a substrate is perfect in this situation. Plenty of tissue thickness. Adam goes ahead and he opaques the restorations. The teeth were a little long. I remember you coming in and saying, these teeth are not really the right shape. And then going ahead, he actually had to add a little bit of pink in that area because we're still a little deficient.
Even with all those surgeries, we're still a little deficient. So this disturbed me quite a bit, but I didn't know that Steve was adding this pink and playing with it at the time.
So I had gold plated it, and I was so proud. This is how she started out, and then this is how it was after the surgery in the pink. Certainly a huge improvement.
Yeah, go back and morph that again. Show them the pre-op.
Before.
And this is what we created up to this point.
Yeah. So basically,
with a little pink.
A little bit pink interdentally. Yeah, because again, all the studies show that it's about somewhat equal in length. So we have
ovate pontic
we have
on top of it.
we have an ovate pontic on top of it. And this is how she looks. And clearly, from what she started out with, this is a huge improvement. Now, again,
this is
how
when
she
I came
looked.
in, right?
Yeah, this is when you came in. I said,
Dennis, take a look. We so I got upset.
You said, what is this stuff over here?
My ego was hurt. After all those grafts, I said, I still can't have the papilla of tissue.
Hey, Steve, do me a favor. Just take this off. Just take it off.
I said,
I'm so upset.
And I said to her, I said, Kristen, I said, just sit down. Let's do one more surgery.
Right.
I'm not charging anything. Just sit in the chair. Let's go. And I did, because I knew this was all soft tissue. I devised this little horizontal incision.
Yes.
And pushed this down. Go ahead. Trying to move this tissue down a little bit more.
Free it up.
I took a large wedge of connective tissue and wedged it in, sutured it in. Go ahead. We move it along. And then I pulled this down, as you see with the suture over this.
Yeah, pulling it over the contact.
And so we took off his pink.
You have to really free this up because that's really the goal.
It was hard. It was scar tissue.
Yeah. How much you free it up becomes a
And here it is. Factor. Here it is at 1 week and 2 weeks. You can see right now it's filled up that gap pretty well. And here it is healed. And she doesn't show that scar up there. It's not in the aesthetic zone. Here it is at 6 months without any pink ceramic. Is it perfect? No, but it's all her tissue.
Yeah, and she's thrilled to death. And she's a school teacher. She's the nicest girl.
This is how we fix this
particular
case. So it's possible to fix these cases. There's the before, and here's the after.
Without the pink.
And we've created, about 6 millimeters of vertical height?
I would say even more, because in Maurice and Henry and David's paper, they said, the potential could be 5.5 to 6, and I think you got about 7 because of the dermis, and the question becomes, what is the potential of dermis and what can be done? So just the implant pontic situation, like I said.
I think this shows that it can be repaired, but it takes a lot of work. Look at what here's the real story today. One mistake at the time of surgery, just lack of understanding of 2 implants next to each other in the high aesthetic zone. Look at what this did. This woman had to go through all these corrective procedures to look normal and to not be a dental cripple for the rest of her life in appearance. Rather amazing.
Yeah, and it's amazing to really fix the problems. It takes like 3 times longer than it is to do it the right way the first time.
Isn't it amazing?
Yeah, it's amazing. But the patients are so thankful. I mean, this is again for pre-op with the pink, porcelain, and with the surgical correction.
And that's
and the letters that they write us at the end, it's really worth it.
Yeah.
Because you really don't, make.
They become your project.
Right, exactly.
So, to summarize, is there a problem? Yes, I think we've isolated. What caused the problem? Two adjacent implants. What is the solution? Supracrestal biologic width. And can we repair the problem? Yes, but it takes a whole lot of work and a great team. Surgeons, orthodontists, technicians, restorative dentists, everybody's got to be
And
on
as you
track.
said, to be a good dentist, you have to have two things. You have to have knowledge and skill,
Right.
and a good team.
And this shows that if you do it right the first time, then you don't have to do
Right.
it again.
Agreed. Agreed.
So we want to thank you. We're looking forward to hearing David, you and Maurice present, and we're also then looking forward to having an interchange and listening to the questions of everybody out there. And we'll stay right on board with you until the end, of course. Thank you so much.
Thank you.